everybody to the Seniors Mental Health Web Education Series. Today we have joining us Dr. Keri-Leigh Cassidy and Dr. Amy Gough, who are part of our geriatric psychiatry team. And they are going to be presenting today on health promotion for older adults. I would just ask people to remember to stay on mute, keep your screens and microphones on mute, and there is a chat. If you have questions, you want to put them in the chat box. It will be monitored, and we will talk about the questions at the end. All right, Keri-Leigh, Amy.
Perfect. Thank you, Sarah.
Welcome.
So like Sarah said, my name's Amy Gough, and this is Keri-Leigh Cassidy with me here, and we're very happy today to speak to you about mental health promotion in older adults. And throughout the talk today, we will focus on not just how this is relevant to older adults, but also in the context of dementia. So the objectives for today are to start off by reviewing the relevance of health promotion with older adults, and then we'll speak about the evidence behind different mental health promotion strategies. And then in the last part of the talk, we will discuss some cognitive behavior therapy methods that you can use for yourself in terms of health promotion, but also with patients in practice or in the community. So to start off with the relevance, the term health promotion is often conflated or confused with the idea of prevention, and there are some similarities, but also differences. So promotion is really about a positive focus on health and well-being, so enhancing those factors, whereas prevention is really about preventing a disease or an illness. So you may be familiar with terms like primary prevention, so preventing an illness from occurring, secondary, preventing it from happening again, or tertiary, managing chronic conditions. So the idea that we'll be focusing mostly on today is promotion, so the addition of health and well-being. The relevance for health promotion in older adults is there are many different reasons why this is important. And some of the areas that we'll get into today are the impacts that health promotion can have on a person's own lifestyle and health behaviors. At a population level, it's also something that's very important because I don't think it's news to anybody in this audience that our population is aging, and there is an extreme cost that goes along with that. So identifying ways to keep people healthier longer and also enhance quality of life is certainly an area of relevance. And we'll also discuss some of the limits of our current medical model, where the focus tends to be more downstream, so on managing the effects of illness once they occur, versus thinking about how can we actually prevent those from happening. And that includes dementia prevention as well. Oh, this was supposed to be a question. No, it still can be a question. So this question here, we're inviting you to think about kind of how much of longevity, so how much of a person's lifespan is actually attributable to their inherited genes. So things that potentially would not be changeable. And I'll ask if anybody's able to put in the chat what they would guess, whether that's 25% of our lifespan attributed to our genes, 50, 75, or 85. Any guesses? 25? Yep, we have a winner right off the bat. So that is often a surprising fact to many people, because I think there's a tendency to think that our lifespan is predetermined by genetics, when actually there's a very significant proportion of our lifespan as one marker of health that could be attributed to things like our behavior and lifestyle factors. So on to the next question, what percentage of chronic disease is attributed to unhealthy lifestyle? So that's referring to things like sedentary behavior, smoking, alcohol use, poor diet. What would we guess for a number there? You can just put it in the chat. 85, yeah, Dave, 85. Exactly. So you're on the right track. This is, again, a surprising statistic to many people, the fact that this much of chronic disease could be attributed to unhealthy lifestyle. And why is that important? Because those are areas that we can directly intervene upon and potentially prevent this huge burden of chronic disease. Oh, yeah, I just because I'm not on viewer mode. Okay, so moving on to get into a bit more detail about the rationale for health promotion. I had mentioned before the cost and the impact to the system. So there are many different estimates as to what the actual cost of dementia is, and it's hard to kind of capture that, especially with all of the costs of informal caregiving that go along with dementia, for example. But estimates suggest that it is at least $10.4 billion per year as a cost to the Canadian economy. So obviously an area that is very relevant to this country, of course, but also globally. These data are actually from the States, but this is just an example of, the costs associated with our health, particularly in the context of aging. And you can see that most costs of the system are spent on medical services. So treatment, like I mentioned before, that downstream approach to actually treating illnesses once they occur, where very little is actually spent on health promotion or preventing these health behaviors. And when we saw the statistic before about how much of our health and chronic disease is attributable to lifestyle behaviors, it brings on this idea of, well, should we potentially be spending more money at the other end? So to actually prevent these things from happening instead of spending a significant majority on the services to treat them. And this image expands on that a bit more by using the kind of classic iceberg image here, where we see that the tip of the iceberg is what we're very used to dealing with, or as healthcare providers, many of us are familiar with, the idea of identifying pathology, treating it, using the medical expertise model to intervene once a person is sick. But what we're often missing with that is everything that is underlying that person's presentation. So the impact of their health behaviors, focusing on their health and well-being, and potentially enhancing those lifestyle factors that could prevent them from becoming ill or delaying that. And coming back to the statistic we looked at a few minutes ago about how such a small percentage of lifespan or longevity is actually attributable to genetics, the other interesting thing that has been coming out in the research is that even that component of our genetics that is potentially predetermined in terms of our health outcomes is potentially modifiable. So studies on epigenetic factors, which means the factors that influence the expression of those genes, are actually directly related to our health behaviors. So for example, here, there's a reference to telomere length. So telomeres are those little things at the end of DNA that protect them and keep our DNA healthy and prevent the expression of things that might manifest as disease. And there's data to show that things like meditation can actually increase those. So to help protect our DNA over time, which again, I think is quite powerful when we think of how positive health behaviors can actually manifest in the body. There are also some barriers to health promotion, and this might be something that comes up in the discussion at the end as well. But many clinicians identify that despite having awareness of the importance of health promotion, not necessarily feeling comfortable in terms of how to apply this into practice, with barriers like lack of knowledge about how to do so, perhaps lack of skill or uncertainty about how to deliver health promotion, or even lack of confidence in how to counsel patients about this. And that's something we'll talk about in the later part of the talk, where we review strategies to apply this. So next, moving on to some more of the evidence behind this. So not only why it's important, but what is some more evidence to support why we would use this type of approach. The Ottawa Charter for Health Promotion was one of the first ever international, came about at one of the first ever international conferences on health promotion, and this was back in the 1980s. And they identified a number of key areas that outlined a roadmap for health promotion. And this was a kind of multi-pronged approach that looked at things like building healthy public policies, creating environments that are more supportive of health, reorienting health services. So what we talked about before with that look at the upstream or kind of preventative factors before people get sick, but also developing personal skills to work on health promotion. And so since that time, there have been a number of public policies and best practice guidelines that have been put in place. And just a few examples that we put on the slide here. The Mental Health Commission of Canada has guidelines for comprehensive mental health services in Canada. CAMH also has best practice guidelines for mental health promotion in older adults. And also the Mental Health Commission of Canada has a good practice guideline for improving seniors' mental health in Canada. So there certainly have been a number of policies developed that support this type of approach. And within psychiatry, which is where we work, there's also been a very significant paradigm shift in terms of moving towards that more positive approach to health. And this is called positive psychiatry, which is an area of psychiatry that was spearheaded by Dr. Dilip Justi, who you can see in the photo on the slide here. And along with his colleagues, he's published a number of books and articles about this topic that really invites us to shift that perspective from just looking at the burden of mental but also physical illnesses, and instead thinking about how can we actually enhance positive psychosocial factors to improve the mental health and well-being of people, but specifically older adults and people who are aging. And this type of approach is also consistent with the Lancet report, which was published several years ago and then has been updated to continue to provide us with more evidence on those lifestyle factors that are associated with dementia prevention. And the Lancet report, the most recent version, has outlined 14 factors that account for almost half of global dementias. And so that's another one of those big statistics that I think is a bit jarring when you think about it, that almost half of the things that could contribute to dementia could be modified. So I think, again, this really brings home that idea of why is it important for us to be thinking about these things? Because we're the people who are working with patients and clients and could potentially be a source of information or engage people in actually addressing these factors to delay or prevent dementia. And so what are those factors? We listed most of them here, and you can see on the slide under 2017, this was kind of the first report that they came out with. And some of those modifiable factors include education level, social isolation, depression, hearing loss, smoking, etc. And in later publications, they've also added additional evidence around alcohol use, exercise, also untreated vision loss, and elevated cholesterol. So as you look through this list here, I encourage you to think about what are some of these things that I could potentially work on people with to address these factors, or also to think, are the people that I work with, are they aware that these factors could potentially be modified to reduce their risk of getting dementia? And this is just another image to help kind of illustrate those risk factors outlined in the Lancet report on dementia prevention and some of the pathways that we see here that merge them together. So you have the full list on the left, but you can see that as you move towards the right, there are different strategies that we could use to potentially address them. So this isn't a whole lot of detail on how to do that, but it's just indicating that there are a number of strategies that would potentially address lots of these areas on the risk factor list. So next, moving on to the idea of brain neuroplasticity. So we saw in the recommendations from the Lancet, that physical activity is one of the areas that is associated with potential dementia prevention. And this example is one that we'd like to narrow in on, because this is one that we often think about when we hear health promotion. It's an area that many people struggle with, and it's also something that has benefits for your health in a number of different areas. So exercise being clearly shown to have positive impacts on mood, sleep quality, physical function, chronic illness, risk of falls, etc. But this is also something that has an impact on brain neuroplasticity, so that ability for the neural networks or neurons in our brains to actually strengthen their connections over time. And this is something we like to highlight because it's a common belief that as you age, it's a steady decline in terms of your cognitive function, but there actually is room to enhance the function of the neural networks in your brain by doing things like exercise. And so in terms of managing things like mental illness as a strategy for, reducing stress and also potentially preventing dementia, because we know depression, for example, untreated is a risk factor for dementia. There are a number of structured therapies, for example, that can be used to treat mental illness and reduce that risk. So things like cognitive behavioral therapy, behavioral activation, motivational interviewing, mindfulness-based interventions. And these are all very effective and also do require training to deliver in a kind of a comprehensive way. So later, in a few minutes, actually, we'll talk about some of the strategies that are informed by this type of psychotherapy, particularly CBT, that can be delivered in a less intensive means without requiring the specific training necessarily in kind of the textbook approach to psychotherapy. And the point of doing that, which we'll cover, is so that this is something that can really be used in your day-to-day practice without necessarily having training in formal psychotherapy. And so, like we just talked about, there are these intensive interventions like the cognitive behavioral therapy, motivational interviewing. They work well, but it is high intensity. And so that's exactly why I said we'll look at something that's more practical and more applicable to a diverse range of providers, which we have with us here today. So this, maybe I'll hand it over to you, Keri-Leigh.
Yeah. Is there a way to do animation of the slides?
Yes, let me just bear with us for 1 minute here, folks. I think I just need to expand this. This. Okay, thanks everyone. Go back a step. There we go. Yes,
Okay.
there we go.
Okay. Okay, so thank you so much, Amy. So the idea here behind behavior change science is based on the model of cognitive behavior therapy, which some of you may be already familiar with, and Amy and I have close to our hearts. We run a cognitive behavior therapy program for older adults with depression. And so this is the basic premise, that there's this interaction between our thoughts, our feelings, and our behaviors, and it's a sort of dynamic interaction. And if we break it down into an example, The thought might be, I don't have time for self-care or exercise. I think a lot of us can relate to that. Being like busy, working, especially people in healthcare are kind of prime examples of being overstretched and maybe not having time for that self-care, which can lead us to be more sedentary. So you can see the impact on behavior. Now, behavior activation would say if we can shift the behavior, let's say start to get out for some walks, then it might shift our thinking. So the impact of getting out for the walk could lead you to think, well, I must care about my health and myself, and I can do this. I can fit in this short walk in the morning, or whatever the behavior might be. So it's just giving you an example of the dynamic interaction that we might see between thoughts and actions. When we can shift a thought and a behavior in a positive direction, then you tend to get also some improvements in mood. So if you were feeling a bit low or anxious, that the behavioral activation can actually improve mood measures. And that's been shown through studies as well. So behavior activation is a component really of cognitive behavior therapy, in which the change begins with the behavior and the impact is felt through both people's thoughts and emotions. And in a way, it is the fastest, most effective way to change thoughts and feelings is through our experience. And so when goals are achieved, there's a thought about self-efficacy, positive self-talk. And then also the important part, when a goal is not achieved, then there's some work on the end of the goal to do problem solving, reformulating, supportive self-talk in order to have success next time. This is based on the Prochaska di Clementi stages of change idea. So when we get into action, whether we have relapse or maintenance, there's this kind of cycle that happens in behind the scenes where we're thinking about it, then we decide to enter the action and so on. And so there's a simpler model to understand the stages of change that Dr. Michael Vallis has developed called stoplight. So in other words, at any point, any person could be red light, not ready, yellow light, ambivalent, or green light, ready to go with any given behavior. And so you can kind of assess that quickly when you're working with a patient in terms of their readiness, when you think in your mind about using the stoplight or even bringing out that kind of a metric to ask the patient. You can ask these questions. Do you consider whatever the behavior is, let's say being sedentary, a problem? Are you bothered by being sedentary? Are you interested in changing that behavior? And are you ready to change now? And so the more positive answers you get there, then more likely they are green, ready to go. And what's behind this model is a basic theoretical mechanism that involves the development of intrinsic motivation over time. So when you start a behavior and you can adhere to it, you get that positive self-talk, which then leads to intrinsic motivation to keep it going. And so the elusive question of like, how do we get our behaviors to change? This is really it, when we can harness this this set of gears in the background to help people shift behavior. So a very powerful combination is when we set a goal that is small enough to adhere to, not judge ourselves when we don't get things done, and combine it with a positive intention of what we can manage to do. This is what builds the kind of brain neuroplasticity, shifts people's wiring in their minds that allows them to develop a new behavior. And it does take some practice. The other important part of like positive psychology and psychiatry is to know what, as it relates to our well-being, what are the kind of behaviors we should go after. So, people often think about happiness coming from, I don't know, the big job promotion or more money or a fancy home or car or vacation, when actually the science would show that the things that actually make the biggest difference to people's well-being are small, doable daily acts, whether it be act of reflecting on one's gratitude, having compassion for others, being kind, creating time to be able to relax and engage in meaningful activities, things that get you into a state of flow where you lose track of time, because you're just so absorbed. These are the things that actually generate a feeling of contentment and happiness. So when we're thinking about what behaviors to add in, anything that fits in these categories is likely to be of benefit to people's health and well-being. So in summary, it's not big Herculean things, but small daily habits that determine people's overall happiness. And habits most consistent among happy people is time with family and friends, gratitude, optimism, savoring pleasures, engaging in meaningful activities, and trying to live in the present with mindfulness practices. And there's a wonderful book here that we're citing that summarizes the science. So coming back to us in our office with our patients and their loved ones, what can we do? How can we help? Even without any kind of training in psychotherapy, there are interventions that have been shown to be helpful. So for example, giving people handouts, written material brochures on this kind of topic. Let's say an example would be handouts that have been given for smoking cessation. And so this would be stopping a negative behavior. Even in that case, you get a 2 to 3% response rate. So if you give out enough pamphlets, you will find that people do shift their behavior with information alone. Another popular area that has come into practice in recent years is writing prescriptions, in this case for positive health behaviors, social prescriptions, prescriptions to go for walks in the woods and so on. And those also do have some benefit where you have a set program, you write it out, you give it to people. And the evidence would suggest that that would give you about a 30% response rate. Even without psychotherapy training, you can also learn how to use a science-based approach to behavior activation. And in that case, where you're individualizing it, you're not prescribing, but you're using a more invitational approach with people, and you're asking them to think about what they would like to do in one of these areas that has science behind it. And in that case, the response rate is up to 80%. In terms of at least partial success in behavior activation. So I think our pitch today really is to encourage people to think about that full spectrum of approaches. And we were going to spend the latter part helping you to better orient yourself to the scientific approach to behavior activation that you could use given the high response rate. So here it is, CBT for you and your practice. And we say it for you because when we bring this kind of approach into our clinical skill set, it does help to practice it on yourself first, because that way you can really understand what the barriers are. So when we think about what Amy talked about earlier, that a lot of times clinicians feel uncomfortable getting into health promotion because they feel ill-equipped to do it. And when you try it for yourself, it gives you a sense of competence. I can do this. And then that brings that gets fed forward into your practice. So Amy and I have been involved in a nonprofit to help translate the science of positive psychiatry using behavior activation for some time now. And we wanted to make you aware of the resources that are all available for free online. And there's a few resources there. There's a free wellness app, which is a web-based program. So you don't go to the app store, you just download it. You just use it, on the internet with a Wi-Fi connection and an email address is all you need. And that allows you to practice this on your own, and you can also share this with patients. The approach that we're sharing with you today has been included in the Mental Health Commission's resource of good practices for improving mental health in Canada for seniors. And that's what that book looks like if you want to review the other things that are embedded in this document. The approach that we're outlining has taken a number of years to develop to try and make sure that it is user-friendly, easy to understand, and translates well into practice. And so this is the model. It uses the acronym THRIVE to basically integrate the science of positive psychiatry, health promotion, and lifestyle medicine, as well as behavior activation science into one easy model. So the acronym THRIVE refers to the areas where there is good science. So our thought patterns make a difference to our health and well-being. Health habits such as physical activity and nutrition, social connection, and the quality of those connections, being able to absorb yourself in genuine interests, and being able to regulate our emotional system using mindfulness and other strategies are all areas that have very robust evidence for improved health outcomes. So it helps you to remember them. And then we've included in this model a 3-step approach that's easy to integrate into practice or to use for yourself. One is to assess a baseline and how you're doing in each of these areas. Second is to set a single goal in one of the areas. And the third, all important, is to track your progress over time. And we suggest a short, discrete amount of time, like a month or so. And Amy's already gone over today some of the evidence behind these areas, but we know that, for example, positive health outlook can add years to people's lives, that chronic disease is very heavily attributed to by unhealthy lifestyle, whereas the opposite's also true. That secure relationships is the highest predictor of well-being into late life. That comes from the Harvard study of longevity. Interests, having ongoing lifelong learning and challenging your brain increases cognitive reserve and lowers dementia risk. That having meaningful activity promotes happiness, and setting goals in those areas is a key to positive psychology research. And in terms of mindfulness and taking care of our emotional well-being, these are we know from our own experiences in the work in psychiatry how important that is. So putting this into practice with the 3 steps, so we broke down, there's the areas and then there's the actual approach in practice. So the steps: assess how you're doing, set one valued goal, track your progress, and repeat. This can be done in using the tools that are available online, or a paper-based approach, which we can also, which is also downloadable on the website. And essentially we have these set of questions that are self-rated on a Likert scale and found to be reliable within the same person. So over time, if there's changes up or down, it's less useful in terms of comparing one person to another. But just that, basically a check-in, which gives you a baseline and how you're doing. And just to kind of, I know it's a little hard to read, but on the left is the paper-based version. So something on the thoughts would be, how would you rate yourself in terms of having positive thoughts, even in the face of setbacks? And you can rate yourself on a scale from 0 to 10, and so on. And these are if you want to take a minute, you can do a little self-reflection. How would you rate yourself, let's say in the last couple of weeks, in terms of being physically active on a scale of 1 to 10, in terms of healthy eating, in terms of having positive social connections, in terms of being interested in learning new things, in successfully meeting goals that are meaningful to you, and overall emotional well-being. So once you have done a self-reflection, it gives you a chance to see where your areas of strength are and where you might need a little extra work. And you can either double down on an area of strength or go after an area that you feel needs a little help. The next step is to ask yourself, what goal would I do? What action would I take in one of these areas? So let's say I've decided I'd like to be more physically active. I would ask myself, what concrete steps would I take? Maybe I'm going to do some yoga in the morning. And why does it matter to me? And how would I measure success? Well, I'm going to maybe do 5 minutes in the morning, 4 days a week. And I got to make sure I have my yoga mat ready. So there's some props and things that might help cue me and make sure I'm supported in that. And that sounds like it would be realistic to do given the busyness of my morning. And I'm going to make sure I pick the time in the morning, because that's a quieter time in the day, and choose the frequency. So this relates to the acronym SMART: specific, meaningful, measurable, action-oriented, realistic, and time-limited. And a lot of the work that Amy and I do working with patients and which you could do if you use this acronym, is help people hone the goal to really be a lot more concrete and specific. When people set goals, we often use the metaphor of apple chopping. So whenever you think of the whole apple as like the goal, how can you cut it down in half or even in quarters, as you see in that orange metaphor? So the idea being people often overreach and are over ambitious in what they set as goals. And we're often working with our patients in the CBT group on how to reduce the goals so it's actually doable. It's very important that it be a doable goal so that it can be accomplished, and then you get the cycle of self-efficacy and the gears moving that I showed you earlier. So the 50% rule is make it smaller and smaller until it's truly a doable goal. So for example, if someone says, I'm going to walk my dog for 10 minutes a day, we may end up with, I'll walk my dog for 10 minutes a day in the morning, at least 3 times a week for the next 4 weeks. You can hear there that it's become more specific and perhaps more realistic when we take into account weather and other factors. These are some examples of other SMART goals that those of us in healthcare might do. Take the stairs at the hospital, call a friend or family member, turn off the phone notifications when you're not on call, those kinds of things. So there's a wide range. You could also imagine goals that might be more suitable for a frail older person or a caregiver, but this just gives you some examples. It's helpful as well when setting goals that this is the difference between the prescriptive approach and invitational approach, is when you invite people to think about a goal they want to do, when they choose something that means something to them, it is more likely to be done. So asking people what matters to you, how much time are you spending on this now? What do you enjoy most in free time? When you're happiest, what are you doing? And those kinds of things. So going after areas of pleasure and joy is a very effective way to set goals. And this is probably one of the more radical shifts of paradigm, if you will, within medicine. We're so preoccupied with what's wrong, with what is, the disease model. It's hard for us to shift into a health promotion model, but this kind of set of questions does help. All right, so I already had alluded to the wellness app, and as mentioned, it is a web-based program that's free and accessible. And some of the features in it includes the ability to help guide a SMART goal setting process. It allows the user to receive notifications to remind them about their goal and encourages them. There's audio encouragement as well, and a calendar where they can log in and record like you would on a regular paper calendar, like a little star on your calendar each day you do the activity. And after 4 weeks, you get a summary and you can check out, then you can continue on, repeat it, and so on. So please feel free to give this a try. This is the website where you can use that and see what it's all about. If you like how it works and you have patients who you think might benefit, then they too could register. For those who've been involved with any of our projects in the past, you might be familiar with this, which is a one-pager, which can be incorporated into the patient's file if you wish, that allows you to track things over time, because it's the follow-up where often we fall down. We ask people about medication and medication compliance, but then also checking in on the goal that was set. To what extent did the patient meet their goal? This is a goal attainment scale. And to what extent did working on that goal impact well-being, and keeping track of this over time. Okay, so just to summarize, we're getting a baseline, we're helping people set a SMART goal and tracking progress. This is a summary slide of the evidence base for this approach. You'll see that this began very grassroots with a clinician-led project. Then we turned it into a peer-led workshop series. Then we tried delivering it one-on-one versus in a community-based group. Then we had a Spark grant from the Center for Aging and Brain Health Innovation for it to be brought into Nova Scotia Health in routine care. Then we had a larger grant from CABI for a national project where we trained clinicians like yourselves across the country to use this approach in practice. And it was a novel KT knowledge translation project where we assessed not only what the clinicians thought of it, but what the patients thought of it and whether it had any impact on the patient behavior when they went through the 3-step process, which led to several publications. And then we had a project through the pandemic where we shifted the model. This is where we developed the THRIVE acronym in applying it not just to older people, but to younger people and those of us in healthcare, and led a workshop project for physicians through the pandemic, and the THRIVE MD project, which followed. Each of these had publications related to them, and so if you're interested, those publications are on the website, or you can reach out to Amy or I for copies. This is a couple of examples there at the bottom of some of our publications, but wanted to just give you the high-level summary of what we found. And that was, regardless of the model, whether it was community-based, group-based, individual, or so on, in over 1,500 people who used the 3-step approach, we found at 4 weeks about 80% at least partially met their goal. They reported improved health attitudes and improved well-being, and that was consistent whether they were doing paper-based approaches or the app-based program. And so just to close then, we encourage you to explore the website where there's materials now set up for individuals, members of the public, for organizations who might want to talk, and also for clinicians who want more training in how to use this approach. So you can explore that there. With that in mind, we do have a couple of projects right now that are funded by the Mental Health Foundation of Nova Scotia to give free education to the public on a couple of these areas. So there's the idea of self-compassionate self-talk, positive self-talk, and training people on that, and the overarching evidence for the domains for the science of healthy aging. So these are available both in English and French, and all webinars are at 7 o'clock Atlantic time, and this is the QR code to register for those. So this is intended for the public. If you have patients or caregivers or others whom you think could benefit, they can join for the free webinars. Maybe we'll find a way to put this info into chat after, or circulate it after the talk today. So to close, we know that health promotion has been heavily emphasized in these national and international best practice guidelines. We're seeing some impact, I think, on the culture in medicine to shift towards thinking about health and well-being in addition to illness intervention. And this stands to benefit people on a population scale in terms of disease prevention. And of course, we're all very preoccupied with dementia prevention, but also intervening when people do have chronic disease or early stages of dementia and other illnesses to curb their course. I just saw an article this morning on the benefit of exercise in bowel cancer recovery, and people with stage 2 and stage 3 bowel cancer who have dramatically improved survival when they engage in exercise and in low inflammatory diet. So the usual, Mediterranean type diet. So this is becoming increasingly relevant, I think, as the evidence and the body of evidence grows across all of medicine, but definitely in psychiatry. And so we'd love to see more people integrate this into their standard practice of care, thinking about the science of behavior change. And please feel free to explore it for yourself, as well as for use with patients. So we'll stop there, and there may be some time for questions. We have a few for you to reflect on. What do you take away from today? What barriers do you see in using this kind of approach in your practice? And what would be the implications of incorporating more health promotion in your practice?
Perfect. I think I'll close this and hand it back to Sarah.
Hi, thanks for that, guys. That's